Our next speaker is the president-elect of the ISNVD, Marian Simka, and Marian will report on his safety trial of CCSVI treatment.
So these are main problems related at the moment to CCSVI. First question is, what is the relationship between multiple sclerosis and CCSVI? Of course, there's a big debate at the moment on this topic. If we decided to do something, is such an approach, especially endovascular treatment, safe or not? And what about clinical result of such treatments? So what about safety? This is our paper published last year in Phlebology. And in this article we describe safety outcomes in the group of over 300 multiple sclerosis patients. You can see the demographics, history of the disease and so on. So it's a whole range of these patients. Before the procedure we performed the Doppler sonography and magnetic resonance venography to know where the problem could be situated. However, the decision what to do, where to do and so on was based on the findings on the catheter venography. In this paper we describe our grading of CCSVI in terms of catheter venography findings. This is grade 1, is slow down outflow with no other signs of impaired venous flow. Grade 2, slow down outflow plus refluxing or pre-stenotic dilation of the vein. And grade 3 is a collateral outflow, and in grade 4 is no outflow to the main vein and instead outflow only to collaterals. So in most of the patients we used ballongioplasty, and of course we used the size, length of the balloons depending on characteristic and localization of the lesions. In some cases we use stents. It was a secondary choice at this moment, and we implanted stent if angioplasty was not successful. Regarding medication, all patients received heparin during the procedure, and after the procedure, after balloon angioplasty, patient received only a low molecular heparin for a week. In the case of stenting, there was a combination of aspirin, clopidogrel, and heparin. So as I've said, the key test for decision making was intraoperative venography, and other non-invasive tests were as a help to look where the problem could be situated, and sometimes, especially in the case of azygous vein territory, magnetic resonance venography is very helpful to know before the procedure that in this particular case can be a very, very strange anatomy. We have two patients with no azygous vein, only with hemiazygous vein. So it's virtually impossible to know it before, and it could be very big problem technically to venography. There was one patient, as I remember, with two azygous veins, very strange, and one azygous vein originated not on the posterior wall of the superior vena cava, but on the right side. It goes to the lung, made a big circle inside the lung, and finally gone to the distal azygos. So sometimes, of course, it's a very uncommon situation, but sometimes this anatomy is very, very strange. It's better to know before. And the result regarding safety. So you can see the numbers. In this group we found venous pathology in almost all of this patient, but of course not in all. It was 97% prevalence of CCSVI. At this time, we implanted stents more liberally, and you can see that in about 40% of the patient we implanted stents. Usually there was only one stent, but sometimes two or even three stents. And what about complications? There was only regarding major complications 2 early thrombosis of the stents. Now we think that the decision of the stent implantation was not proper. It was in the case of hypoplastic veins, and these stents occluded very, very quickly. One occluded immediately on the table, and in second phase it was during the first post-procedure day. Regarding minor complications, there were some local bleedings, some cardiac arrhythmias, and some technical problems, but not many. At the moment, we have 4 papers published. In total, as you can see, it's over 1,100 patients described in those papers, and in total there were no major complications, no deaths, no fatalities. The only complications that were described in these papers were early thrombosis. Perhaps, at least in some of these cases, were due to improper choice of this technique. Also, in all of these papers were described other minor problems like this cardiac arrhythmias, minor bleedings, but not very often, and all of them were either transient and with no severe complications and no sequelae. Regarding late complications, at the moment we have no published paper, but we all know that there are some problems, and I think the most important problem is the late occlusion of the stents, mostly due to intimal hypoplasia, sometimes due to thrombosis. Unfortunately, there is no good data how often this occlusion of the stent occur, but based on our records and also personal communications, we think that is not a very often situation. That it happens that perhaps less than 5% of implanted stent occlude, but if it happens, it's very difficult to reopen such an occluded stent. In many cases, it's virtually impossible. And can the safety be improved? So we now know that most of complications after endovascular treatments for CCSVI are related to, firstly, to use of anticoagulants. I know about 3 fatal outcomes after these procedures, all of them related not to procedure by itself, but to bleeding. So, of course, we don't know, but maybe multiple sclerosis patients are at high risk of bleeding after the use of anticoagulants. Maybe these drugs are simply contraindicated in the patients. We don't know. Second problem is the use of stents. Of course, most of these procedures went uneventfully, but these problems may occur, and they are reported occlusions, migrations, and again, problem with the drugs. And the third group is restenosis due to too aggressive technique, scarring in the area of angioplasty. And how can we lower the rate of these infrequent but potential problems? So perhaps we should avoid stenting whenever possible. In some centers, including also our hospital, we use rather cutting balloons instead of stents in a case of not responding restricting annulus in the area of valve or upper jugular vein. Also, we use cutting balloons instead of high pressure or oversight balloons. In a case of hypoplastic veins, in some cases we perform this procedure in more than one stage. In the first stage we perform only the gentle angioplasty, and then we follow the patient. Sometimes we perform a second procedure after several months. We feel now that it's much more safer than doing everything during first procedure, which eventually may fail and result in total occlusion and irreversible damage to such a vein. And of course the learning curve apply as everywhere. So these are cutting balloons. These are our rates of stenting procedures. So initially we implanted a lot of stents. We have hundreds of patients. So this last 100 it was about 5%. Now our rate is even lower, is about maybe 2 or 3%. Not much. Virtually never during the first procedure. And here's our complication rate of our last 500 procedures. So it is slightly improved. Still no serious problems, but we have no early thrombosis of stents. Also this local bleedings rate improved, I think due to learning curve. And we have no cardiac arrhythmias, perhaps also due to improved technique. Thank you very much. Yes, yes. Anyway, these patients perhaps, of course, there are no data on it, but perhaps they are on a higher risk of bleeding and on a higher risk of fatal bleeding. So, if not necessary, don't give. Perhaps these drugs should not be given to them. That is first, and second, avoid situation where such a drugs will be needed. Of course, there are no data, but there are some very very sad outcomes. Yes. You know, in our hospital, these procedures are performed by vascular surgeons. So for us, there's no problem, but it's a complication. Sometimes after balloon rupture, it's virtually impossible to remove this equipment, and you should open the femoral vein and open it. Fortunately, the patient are in proper hands, so it's not for us. It's not a big problem. Anyway, a complication.